Have you ever been told you need to get cleared for surgery? It sounds a bit mysterious, doesn't it? Like you're passing some kind of special test for your own body.
Ah,
Well, today we're sort of pulling back the curtain on that whole experience. We're taking a deep dive into the preoperative assessment, that absolutely vital step before any procedure that needs anesthesia. Our mission really is to turn this often overlooked medical thing into something genuinely interesting. We want to show you the intricate layers of care that are designed specifically to keep you safe and, well, optimize your outcome. We'll touch on everything from the different kinds of anesthesia to, why your morning coffee might matter more than you think, and even some surprising family history details that turn out to be pretty critical.
that's absolutely right. This isn't just about ticking boxes on some form. It's really about understanding your unique physiological blueprint. The whole point is to craft the safest, most effective plan possible for you. It's about minimizing risks and making sure you have the best possible recovery. It's a really comprehensive look at you for your benefit.
Okay, right, let's unpack this. What is anesthesia exactly? I think most of us just picture it going to sleep, but it's clearly more nuanced than that.
Oh, definitely. Anesthesia involves using medication to achieve basically three core goals. First, analgesia, that's the loss of pain. Second, amnesia, which is the loss of consciousness. And third, muscle relaxation, meaning the loss of movement.
Okay.
And to do that safely, we have different categories, and some require a qualified anesthesia provider. So first, there's general anesthesia. That's a drug-induced state where you're completely unconscious, you're not arousable even by pain, and you often need help with your breathing.
Right.
Then you have regional anesthesia. Here, the anesthetic is delivered near specific nerves, think epidurals or spinal blocks. You're conscious, but you lose feeling and movement in a specific area.
Okay.
But the key thing here is, even with regional, there's always a chance it might need to be converted to general anesthesia during the surgery. That's why an anesthesia provider has to be there. And finally, there's monitored anesthesia care, or MS. This involves a qualified practitioner closely monitoring you, giving sedative meds, and they're always ready to deepen the anesthesia or intervene if needed.
Okay, that covers the main ones requiring a provider. But you mentioned a surprising side to sedation. What about things that don't need that level of supervision?
Exactly. So topical or local anesthetics, those are just simple numbing agents for a small area. Think getting stitches. Then there's minimal sedation. Here, you respond normally to voices, like maybe for an MRI or CT scan to help you relax.
Okay.
And then moderate sedation, sometimes called conscious sedation, you can still respond purposefully to commands, maybe a light touch. Crucially, your breathing is usually fine on its own. This is common for things like, say, some dental procedures or maybe a straightforward breast biopsy.
I see. But what if something goes deeper than planned with moderate sedation?
That's a really critical point. Hospitals must have procedures in place to rescue a patient if their sedation unexpectedly becomes deeper. They need to be able to immediately manage the airway and breathing. It highlights how fine the line can sometimes be between these levels.
Yeah, knowing the difference seems crucial for safety. So who's overseeing all of this, making sure these safety nets and standards are actually followed?
Right. It's not just the individual hospital or clinic. There are key regulatory bodies involved. You've got the Centers for Medicare and Medicaid Services, or CMS. There's also the Joint Commission on Accreditation of Healthcare Organizations, JCHO. You often hear them called the Joint Commission.
Okay.
And then professional organizations like the American Society of Anesthesiologists, ASA, and the American Association of Nurse Anesthetists, AANA, also set important standards and guidelines.
And what do bodies like CMS actually require for this pre-anesthesia check?
Well, CMS regulations are quite specific. A pre-anesthesia evaluation must be performed for any patient getting general, regional, or MBA. And it has to be done by a qualified provider within 48 hours before the procedure.
48 hours, okay.
But importantly, CMS does not mandate the same formal evaluation for moderate sedation.
Okay, here's something I find really interesting from a safety angle. JACHO's Universal Protocol. What's that about?
Yes. The Universal Protocol is all about preventing mistakes, specifically wrong site, wrong procedure, or wrong person surgery. It's incredibly important.
Absolutely.
It involves three key steps. First, a pre-procedure verification process, making sure all the documents and expectations match up. Second, marking the actual procedure site on the patient's body. And third, performing a timeout just before the procedure starts. Everyone stops, confirms the patient, the site, the procedure one last time.
The patient is involved in this.
Absolutely. You, as the patient, are actively involved in that verification. They'll ask you to confirm your identity using at least two identifiers, usually your name and date of birth, maybe your medical record number.
Got it. So what actually goes into my personal pre-anesthesia evaluation? What information are they gathering?
It's quite comprehensive, really. It's a deep dive into your medical story. It includes your complete medical history, of course, but also any previous experiences you've had with anesthesia, good or bad. Any drug or allergy history is vital.
Right.
There's usually an interview and a physical examination. You'll also be assigned an ASA classification.
ASA classification, what's that?
It's basically a standardized way anesthesiologists assess your overall physical health. ASA1 being a healthy patient, going up to AS66 for a declared brain-dead patient whose organs are being removed.
I see.
The team will also discuss any potential challenges they foresee, like maybe predicting a difficult airway, risk of infection, IV access issues, or that risk of malignant hyperthermia we mentioned. They might order additional tests if needed, like stress tests, labs, maybe consultations with other specialists.
Okay.
And finally, they'll discuss the proposed anesthesia plan with you, including the risks and benefits.
So if you connect all those dots, all these regulations, protocols, the evaluation itself, it's all geared towards what?
It's all designed to optimize your care, minimize morbidity and mortality, that means complications and death, reduce delays on the day of surgery, and ultimately to formulate the very best, safest anesthesia plan specifically for you. It's a very structured approach to deeply understanding the individual patient.
It really is. And speaking of understanding the individual, you mentioned demographics. What kind of details are relevant now beyond the basics?
Yeah, things like current gender identity, sex assigned at birth, and preferred pronouns are becoming standard and important parts of the record. It's about providing personalized, respectful care for everyone.
That makes sense. And you also hinted at surprising allergy connections.
Right. This is fascinating. For example, there's a known link between allergies to certain fruits like kiwi, bananas, nuts, avocados, and latex allergy.
Really? I wouldn't have guessed that.
It's a cross-reactivity thing.
Yeah.
Also, if you have a shellfish allergy, they need to be cautious with iodine-containing solutions like betadine, which is often used for skin prep.
Wow.
And there's a potential issue with egg or soy allergies and the anesthetic drug propofol, particularly a caution in pediatric patients. These little details can be genuinely life-saving.
Okay, let's shift gears to the medication maze. This is definitely where I and probably many listeners get confused. What do I stop? What do I keep taking?
It is confusing, and it's super important to get right. There are solid reasons for holding specific medications before surgery. Primarily, it's often about reducing bleeding risk during or after the procedure, also avoiding potentially harmful drug interactions between your home meds and the anesthetic drugs, and preventing other complications.
Can you give some common examples? Like, what about blood thinners?
Sure, blood thinners or anticoagulants are a big category. The advice depends on the specific drug and the type of surgery. So things like NSAIDs, ibuprofen, naproxen might be stopped 5 to 7 days before, depending on the procedure's bleeding risk. Aspirin is often similar, maybe 5-7 days. Unless it's prescribed for a specific cardiac reason, then the decision is more complex.
Right.
Newer drugs, DOACs, might be held for 24 to 48 hours, sometimes longer, depending on kidney function and the surgery's risk level. Clopidogrel, Plavix, is usually stopped 5-7 days prior. Warfarin, Coumadin, needs about 3-5 days, and they'll check your INR, that's a blood test measuring clotting time before surgery.
Okay, so it's very specific.
Very. Even heparin infusions are usually stopped 12-24 hours beforehand, often with a blood test check too. It depends on bleeding risk categories, minor, low, high-risk procedures.
What about things like herbal supplements? People don't always think of those as medication.
That's a crucial point. Many common supplements need to be stopped, often 1 to 2 weeks before surgery. Garlic, ginkgo biloba, ginseng, even high-dose vitamin E can increase bleeding risk or affect blood sugar. You have to tell your team about everything.
Okay. And diabetic medications.
Another important group. Metformin is usually held the day of surgery and for 48 hours after. This is because of a rare but serious risk called lactic acidosis, especially if your kidney function changes around surgery time.
I see.
Other types, like sulfonylurias, are often held the morning of surgery simply to prevent your blood sugar from dropping too low while you're fasting.
And what about those newer weight loss drugs, the GLP-1 agonists like Ozempic or Wegovy? They seem to be everywhere now.
Yes, this is a relatively new consideration and really important. The current recommendation from the ASA is to hold daily doses on the day of surgery. Hold it for a full week before the procedure.
Why is that?
It's because a major side effect of these drugs is delayed gastric emptying. Your stomach doesn't empty as quickly as it normally would.
Ah, so even if you followed the fasting rules.
Exactly. Even if you fasted correctly, your stomach might still contain food or liquid. This creates a full stomach situation, increasing the risk of aspiration during anesthesia. If these meds weren't held as advised, the anesthesia team has to treat you as if you have a full stomach, taking extra precautions. It's a significant safety issue. The ASA notes there's no proven optimal fasting duration yet, but these are the current guidelines.
Okay, that makes sense. So lots of things to potentially hold. What about medications that usually continue?
Generally, most antihypertensives, blood pressure meds like ACE inhibitors, ARBs, beta blockers are often continued, maybe even taken the morning of surgery with a sip of water, but always follow specific instructions. And most psychotropic medications like antidepressants or anti-anxiety meds are usually continued as well. Stopping them abruptly can cause issues.
This really underscores something you touched on. Why is it so critical to report everything? Over-the-counter stuff, supplements, everything.
Because every single substance you take can potentially interact with anesthesia, affect bleeding, blood pressure, or healing. It's about preventing a potential cascade of complications. The team needs the full picture to create the safest possible plan for you. Incomplete information is a major risk.
Right. And it's not just meds, is it? Lifestyle factors play a role too, like smoking.
Huge role. Cigarette smoking significantly increases risks, especially pulmonary complications, about 6 times the risk, actually. It also increases heart rate, blood pressure, oxygen consumption, and the level of carbon monoxide in your blood.
Wow. Does stopping help even shortly before?
Yes. The good news is even short-term quitting just 12 to 48 hours before surgery can make a difference, particularly by reducing that carboxyhemoglobin level. Longer is better, of course.
What about alcohol?
Alcohol use also increases risks, maybe 2 to 5 times the risk for complications. Chronic heavy use can mean you actually need more anesthetic, but acute intoxication, being drunk when you come in for surgery, usually decreases the amount needed. Either way, it complicates things.
And other drug use.
Yes, illicit drug use needs to be discussed honestly. Marijuana use can affect memory, blood pressure, heart rate, making them less stable under anesthesia. Stimulants like cocaine or amphetamines mean the anesthesia team needs to avoid certain drugs like ephedrine, which could cause a dangerous heart reaction.
And prescription pain meds.
Important to document, if you're regularly taking prescription opioids, you likely have an increased tolerance. This means managing your pain after surgery might be more challenging and require different strategies.
Okay, moving deeper into medical history. What about your personal anesthetic story, previous reactions?
Absolutely key. They'll ask about any personal history of adverse reactions, things like severe postoperative nausea and vomiting, PONV, any known difficult airway experiences previously, any history suggestive of malignant hyperthermia, MH, serious allergic reactions, anaphylaxis, or unexpected cardiopulmonary issues during anesthesia, or even an unanticipated admission to the hospital after what was meant to be outpatient surgery.
And family history comes into play here too, right? You mentioned MH.
Yes, critically. Family history is screened for specific, often inherited conditions related to anesthesia. Malignant hyperthermia is a big one. It's an autosomal dominant disease, meaning you only need one copy of the gene. While rare, maybe 1 in 15,000 anesthetics, it's potentially lethal.
What happens in MH?
Certain triggers, mainly inhaled anesthetic gases, and a muscle relaxant called succinylcholine can cause a hypermetabolic state. Early signs are subtle, rising carbon dioxide levels, fast heart rate. Later signs are dramatic, muscle rigidity, a rapid spike in temperature. Crucially, if it's not recognized and treated immediately, death occurs in about 75% of cases.
Wow. How's it treated?
Rapidly. Stop the triggering agents immediately, give 100% oxygen, administer a specific drug called dantrolene or Ranadex, actively cool the patient. It's an emergency protocol. Knowing the family history allows the team to use completely different, safe anesthetic drugs from the start.
Are there other inherited conditions they screen for?
Yes. Atypical pseudocholinesterase deficiency is another. It's an enzyme deficiency. Normally, this enzyme breaks down succinylcholine quickly. If you have the atypical form, especially the homozygous type, the drug's effect can last for hours, like 6 to 8 hours instead of minutes. You'd need prolonged breathing support.
Okay.
And porphyria. This is a group of disorders caused by a defect in heme synthesis, part of hemoglobin. Certain drugs can trigger a severe attack in susceptible individuals. The list includes common drugs like barbiturates, diazepam, lidocaine, sulfonamides, amphetamines, so knowing is vital to avoid them.
Given all these potential issues, you'd think everyone gets a ton of lab tests before surgery.
You might think so, but actually the ASA guidelines recommend against routine shotgun approach testing if there's no specific clinical reason.
Oh, okay. So tests are ordered based on.
Yeah, based on your history, your physical exam, the type of surgery. So they might order things like a CBC, complete blood count, tests for kidney or liver function, electrolytes, blood glucose, maybe a urinalysis, coagulation tests like INR or PTT if you're on blood thinners or have a bleeding history. An EKG is common, especially for older patients or those with heart history, usually within 30 days if stable. Maybe a chest X-ray or pulmonary function tests, PFTs, if significant lung disease is suspected. But it's targeted, not routine for everyone.
Got it. And then there are the fasting rules, NPO. Can you quickly run through those again?
Sure, NPO stands for nil per os, Latin for nothing my mouth. The standard ASA guidelines are clear liquids like water, black coffee, clear juice without pulp stop 2 hours before. Breast milk stop 4 hours before. Infant formula, non-human milk like cow's milk, or a light meal like toast and clear liquid stop 6 hours before.
Okay.
And a full meal, anything heavy, fried, fatty, or meat stop 8 hours before anesthesia.
And this connects back to what you said about the GLP-1 drugs and the full stomach risk.
Exactly. These rules are all designed to minimize the amount of content in your stomach when anesthesia starts. The major risk we're trying to avoid is aspiration stomach contents coming up and getting into the lungs. That can cause serious pneumonia or lung injury. It's a fundamental safety measure.
It really highlights the detail involved. Let's talk about assessing specific body systems. Why does, say, the cardiovascular system get so much attention?
Well, surgery and anesthesia put stress on the heart and circulation, so understanding your baseline is key. A simple question like, can you walk up a flight of stairs without getting short of breath? Tells us a lot about your functional capacity, your MET score, basically.
Right.
We know that having had a heart attack, MI, within the last 6 months significantly increases the risk of another cardiovascular event around surgery time, maybe an 8-fold increased risk of stroke, for instance. Guidelines generally suggest waiting at least 60 days after an MI for elective, non-urgent surgery.
What about devices like pacemakers or ICDs?
It's very important. The team needs to know the type of device when it was last checked. For ICDs, implantable cardioverter defibrillators, electromagnetic interference from surgical equipment can sometimes trigger an inappropriate shock. So often, a magnet is placed over the ICD during surgery to temporarily disable the shocking function while keeping the pacing function active if needed.
Okay.
And stents, also crucial. After getting a stent, you're usually on strong anti-clotting medications. For a bare metal stent, you typically need to wait at least 3 or 4 weeks for elective surgery. For a drug-eluting stent, it's much longer, often recommended 12 months, because stopping those anti-clotting drugs too soon carries a high risk of the stent clotting off.
Okay, moving to the lungs, the respiratory system, what are they looking for there?
Key things include a history of asthma, how severe is it, have you been hospitalized, how often do you use your inhaler, taken steroids recently. Also, any recent upper respiratory infection, URI. If you have significant symptoms like fever, thick secretions, a productive cough, elective surgery is usually postponed, often for about 4 weeks, to let the airway inflammation settle down. We also know that pulmonary complications increase as the anesthetic time gets longer, especially approaching 2-3 hours.
And sleep apnea.
Yes, screening for obstructive sleep apnea, OSA, is standard now. They'll ask about loud snoring, witnessed pauses in breathing during sleep, choking or gasping, and excessive daytime sleepiness. Patients with OSA often require special handling during and after anesthesia because their airway can obstruct more easily.
And the endocrine system. Diabetes, thyroid.
Very relevant. Diabetes brings increased risks of coronary artery disease, high blood pressure, heart failure, nerve damage, autonomic neuropathy, and that delayed stomach emptying, gastroparesis we mentioned. Some diabetics also develop stiff joint syndrome, particularly affecting the neck and jaw, which can make intubation more difficult. Thyroid disorders need to be reasonably well controlled. Severe hyperthyroidism can make you more sensitive to anesthetics and prone to low body temperature. Hyperthyroidism, if uncontrolled, can lead to thyroid storm, and a large goiter might even obstruct the airway. And adrenocortical disorders like Addison's disease or Cushing's, or even just recent significant steroid use, might mean you need supplemental stress dose steroids around the time of surgery to cope with the physiological stress.
So gathering all this system info plus the physical exam,
Mhm.
a big part of that exam is looking at the airway, right? What exactly are they assessing for intubation?
That's right. Assessing the airway is paramount for safety if general anesthesia or deep sedation is planned. They use several methods. The Malampati classification is a common one. You open your mouth wide and stick out your tongue, and they see how much of the back of your throat is visible. They measure thyromental distance, the distance from the tip of your chin to the notch in your thyroid cartilage. Less than about 7 centimeters can suggest difficulty. They check your incisor gap, how wide you can open your mouth, neck movement, atlanto-occipital extension, and your dentition, any loose teeth, grounds, bridges, braces that could be damaged or obstruct.
What are some common factors that might signal a potential difficult airway?
There's quite a list. Things like obesity, being edentulous, no teeth, which can make mask ventilation hard, having a beard, known OSA, also increased neck circumference, having a large tongue, any facial or neck deformities, history of radiation or trauma to the neck, certain congenital abnormalities like micrognathia, small jaw, Treacher-Collins syndrome, Pierre-Robin sequence,
Yeah.
and conditions like severe rheumatoid arthritis, Down syndrome, scleroderma, or significant cervical spine disease can all make airway management more challenging.
Wow. It's fascinating how many physical clues are assessed just to predict and prepare for that one critical step.
It truly is. The goal is always to anticipate potential difficulties and have multiple plans and backup equipment ready before anesthesia even starts. It's all about ensuring safety.
So all this assessment feeds into crafting the actual anesthesia plan, and you said it's not one size fits all.
Definitely not. The final plan is tailored based on several things: your overall physical status, that ASA score, the specific type and expected length of the surgical procedure, and importantly, your preference.
My preference matters.
Absolutely. For instance, if a regional technique might be ideal from a medical standpoint, but you strongly refuse it after understanding the pros and cons, the team will respect that and offer safe alternatives, usually general anesthesia, and discuss that plan with you.
Which brings us to informed consent. What does that really mean in this context?
Informed consent is fundamental. It's your right to understand what's being proposed to the anesthesia plan, including the potential risks, benefits, and alternatives, and then to voluntarily agree to proceed.
It's not just signing a form.
No, it's a discussion. Legally, it protects against claims like battery, unauthorized touching, or negligence, failure to warn. The AANA actually recommends having a separate consent form specifically for anesthesia, distinct from the surgical consent, to make anesthesia's role and risks clear.
Okay. And who can give consent?
Generally, you need competence, legal authority, usually being 18 or older, and decision-making capacity. Capacity means you can understand the information and make a meaningful choice at that time, considering factors like pain or medication effects.
What about special situations?
Yeah.
Minors? Refusals?
Right. There are exceptions for minors like emancipated minors, those in the military, sometimes pregnant minors, or for specific services like substance abuse treatment. Patients absolutely have the right to refuse treatment, even life-saving treatment, provided they have capacity. This includes situations involving language barriers, disabilities, or religious reasons, like Jehovah's Witnesses refusing blood products. The team documents this and explores alternatives.
What about DNR orders in the operating room?
That's a complex discussion that needs to happen beforehand. Often, DNR orders are temporarily suspended during surgery because many anesthetic interventions technically mimic resuscitation efforts, but it's decided on a case-by-case basis with the patient or surrogate. And of course, in a true life-threatening emergency where consent isn't possible, treatment necessary to save life or limb usually proceeds under implied consent.
It's a detailed process. Let's demystify the risks a bit. What are common versus serious risks for general anesthesia?
Okay, for general anesthesia, frequent or common risks are usually minor, though annoying. Things like oral or dental damage from the breathing tube, sore throat, hoarseness, postoperative nausea and vomiting, PONV, drowsiness or temporary confusion, sometimes urinary retention.
And the less frequent but more serious ones?
Infrequent but serious risks include things like awareness under anesthesia, rare but distressing, visual loss, very rare, major blood loss requiring transfusion, aspiration pneumonia. Also, catastrophic outcomes like organ failure, malignant hyperthermia, severe drug reactions, failure to wake up properly, or even death, though death solely due to anesthesia in healthy patients is extremely rare nowadays.
Okay. And what about risks specific to regional anesthesia, like spinals or epidurals?
With regional, frequent issues might include prolonged numbness or weakness beyond what's expected, a postdural puncture headache, PDPH, if the dura membrane is punctured, especially with epidurals. And sometimes the block just doesn't work perfectly, maybe it's patchy or wears off too soon, requiring conversion to general anesthesia. That's considered a technique failure.
And the serious risks for regional.
Infrequent but serious risks include bleeding around the spinal cord, hematoma, infection, direct nerve damage, potentially causing persistent numbness, weakness, or paralysis. Very rare. Also, seizures if the local anesthetic accidentally gets into the bloodstream in high doses, coma, or, again, in extremely rare circumstances, death.
Hearing those serious risks laid out, why is it so vital to have these candid discussions, even about the rare stuff?
Because it empowers you, the patient. True informed consent means understanding all potential outcomes, however unlikely. It allows you to weigh the benefits against the risks realistically and participate fully in the decision-making about your own body and health. It builds trust.
What an incredibly detailed journey we've been on today. We went from the basics of anesthesia types all the way through this meticulous review of personal history, meds, lifestyle, body systems, and it's all guided by these really rigorous standards and safety protocols.
It really is. The preoperative assessment is, I think, a powerful testament to the personalized, vigilant care that goes into modern medicine. It's designed to navigate the complexities of surgery safely and effectively. It's this incredibly detailed process that really sees you as a whole person, not just a procedure slot. They're planning for you.
So let's leave our listeners with a final thought to mull over. Given just how much detailed information goes into this assessment, think about this. What personal health detail, maybe something seemingly small, might you have overlooked in the past that could actually be crucial information for your anesthesia provider? And maybe more broadly, how can you use this deeper understanding we've talked about today to be an even more active, informed participant in your own healthcare journey? Really think about what you've learned and maybe how it changes your perspective next time you hear someone needs to get cleared for surgery.